everyone, this is a demonstration of the respiratory exam. There are 4 components to the exam. They are inspection, palpation, percussion, and auscultation. Our patient is going to be seated on a chair without back support throughout the entire exam. The practitioner will stand to the side of the patient to perform the exam. Because we need to work on the anterior chest and the posterior chest, there are 2 options for your order. First one, you can perform a component on the anterior chest and posterior chest before moving on to the next component. The other option is to perform all 4 components on the anterior chest and then having the patient turn around and perform the whole components again on the posterior chest. Personally, I prefer to do everything on the anterior and then moving on to the posterior. This saves me a bit of time without having to move around too much, and particularly important when you're working with a female patient so that you don't need to switch the gum over multiple times. So that is the order I'm going to demonstrate today. I'm going to start with inspection. Now, inspection is easy enough to perform on the anterior and posterior chest. So we'll do the whole thing there. So I'm going to look for scars, masses, and rashes in the chest region. Remember, we're looking on the anterior chest, and you must walk around to look for those on the posterior chest as well. Next, we're looking for cyanosis and finger clubbing. So cyanosis is best observed at the tip of the nose, the lips, the earlobes, and then the fingertips. While I'm looking at the fingertips, I'm going to observe the shape of the nails to look for any evidence of finger clubbing. I'm then going to ask the patient to push the nail beds against each other like so, and observing the fingertips. If they are pointing away from each other, this could indicate finger clubbing. Next, I'm going to observe the rib cage for any asymmetrical movements when the patient is breathing in and out. Also looking for any deformities such as pectus excavatum, pectus carinatum, barrel chest, and scoliosis. And then I'm going to stand on the side of the patient and observe the A2P diameter of the rib cage. If that diameter is increased, this could indicate barrel chest. And then we're going to observe the patient's breathing rate and rhythm. For the purpose of the final practical exam, you don't need to count the patient's breathing rate. I'm also noting any abnormal sounds that I may pick up here, such as wheezing, and looking for any use of accessory breathing muscles, particularly the trapezius, the scalenes, and the abdominal muscles. And lastly, I need to make sure that the trachea is midline. So in this case, we need to displace the facial hair to look for the trachea. Next, I'm going to move on to palpation of the chest. So with the palpation, I'm going to be performing that with the heel of my hand. To start off with, I'm going to palpate along the sternum and also the ribs. As I'm doing so, I'm noting any areas of deformity or any tenderness, and they may indicate a past or a present injury. Be sure to cover each single rib as you go along. And on the other side. As I'm performing the palpation, I like to support the back of the patient with my other hand. Now don't forget to palpate the side of the rib cage, and you can do that by having the patient lifting their arms up. And relaxing down. While I'm here, I'm going to palpate for the trachea, make sure it's a midline. So I'm going to use my index finger or my middle fingers. I'm going to gently place them on the suprasternal notch and feeling for that trachea. I'm now going to ask my patient to swallow. This will push the trachea anteriorly and making any lateral deviation easier to detect. And the next component in palpation is tactile primitives. So once again, using the heel of my hand, I'm going to follow that pattern we have talked about multiple times. Side to side, top to bottom. Side to side, top to bottom. So every time we make contact with the patient's chest, we're going to ask the patient to say 99 in a normal voice.
99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
For tactile perimeters, we're looking for the amount of vibration that we can feel underneath our hand. For a normal patient, we should have roughly around the same amount of vibration at each point. If you come across an area where the vibration is increased, this could indicate consolidation, such as the case of pneumonia. If the vibration is decreased in an area, this could be due to COPD, where too much air is trapped in the lungs, or it could be pleural effusion, where there's too much fluid in the pleural space, or it could be pneumothorax, where there's air trapped in the thoracic cage. Next, I'm moving on to percussion. The technique is very important here. I'm going to use my left hand as the contact hand. Particularly, I'm going to contact the patient's body or the chest area with the dip of my contact hand. I will then strike that dip with the tip of my strike hand, of the middle finger. So once again, as I'm performing percussion, it will be following that same pattern, side to side, top to bottom. As you are percussing, be sure that you are percussing in the intercostal space to produce a nice resonant sound. If you were to percuss over the ribs or the clavicle, then the sound can become dull. A normal percussion sound in the thoracic region should be resonant. If you come across a dull sound, this could indicate consolidation, such as pneumonia. If the sound is a stony dull, then this could indicate pleural effusion. If the sound is hyperresonant, this could indicate emphysema, where there's too much air trapped in the lungs, or pneumothorax, too much air trapped in the thoracic cage. Once again, you are expected to verbalize these findings as part of the final exam. Now, for the anterior chest, we also need to percuss for the upper border of the liver. Our liver is on the right-hand side of the body. To locate this, we need to firstly find the mid-clavicular line. So from the midpoint of the clavicle, this is the line we're going to now percuss along. As I'm percussing down the line, that sound should once again be resonant. It will remain resonant until I reach the top border of the liver, where it will become dull because liver is a solid organ. So for this patient, and I hope you can hear this on the camera, the sound right here is resonant. But as we move down slightly, it becomes dull. So we know for him that the border of the liver is in this region here. And now we move on to auscultation. For the purpose of this demonstration, I'm going to place the earpieces around my neck. However, in the final examination, you will need to actually perform auscultation by having the earpieces in your ears. I'm going to make sure that the diaphragm of my stethoscope is engaged. And once again, I'm going to listen following that same pattern we had previously. As I'm listening, I need to make sure that the breath sound I hear in each region is what I would expect. So in the periphery of the lungs, a normal breathing sound is vesicular. As we go a little bit more central, where the lumen becomes bigger, we are expecting to hear bronchovesicular sounds, and those are usually detected on the upper third of the chest region. So anteriorly, it will be right around here, and on the posterior chest, it will be between the scapula. And lastly, as I listen along the midline, I should hear a bronchial sound as the air is passing through a bigger lumen. If I have an area where the sound is decreased, that could indicate emphysema, pneumothorax, or pleural effusion. If I hear bronchial sounds in an area where the sound should be vesicular, this could indicate consolidation. I'm also listening out for adventitious sounds such as crackles, wheezes, stridor, and rhonchi. So once again, this is what you have to verbalize in the final practical exam. So now, every time I am auscultating, I need to ensure that I can hear a whole breath before moving on to the next point. Now, as part of auscultation, I'm now going to perform bronchophony. This is where I will place the stethoscope on the patient again, but this time I'm going to ask the patient to say 99 in a normal voice.
99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
In a normal patient, that sound should be quite muffled and unclear. However, when a patient has a clear sound or quite distinct sounds, that would indicate bronchophony, which means the patient has consolidation in that particular area, okay, to make that sound very clear. Now I'm going to move on to the examination of the posterior chest. In real life, you will simply move to the back of the patient to perform that test. But for the purpose of the camera, I'm going to ask my patient to turn around. Now, because I have performed inspection before, I'm moving straight onto palpation. And before I do anything, I'm going to ask the patient to give themselves a hug. And now I'm going to perform palpation using the heel of my hand. Once again, I'm going to support by holding onto the patient's elbows on the front. And now palpating along the ribs to look for any areas of deformity or tenderness. Next, I'm going to move on to tactile perimeters. So once again, with the heel of my hand, every time we make contact, we're going to ask the patient to say 99 in a normal voice.
99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
And that's it. Now, you do not need to verbalize the normal and the abnormal findings again, because you have already done so when performing them on the anterior chest. Next, I'm going to move on to a special component of palpation that's only on the posterior chest, and that is examining for chest expansion. So for this one, I'm going to ask the patient to relax their arms down by their side. I'm going to locate the T6 spinous and place my thumb on either side of the T6 spinous. I will then wrap my fingers around the rib cage. From here, I'm going to ask the patient to breathe out, and this makes the rib cage in the smallest diameter. And now from here, I'm going to ask the patient to take a deep breath in, and I'm going to follow the movement of the rib cage as their breath is taken in. And that distance between my thumbs is going to be the chest expansion. You can breathe out now. For a male patient, normally it should be more than 2 inches, and for a female patient, it should be more than 1.5 inches. And now moving on to percussion. So once again, asking our patient to hug themselves to laterally deviate our scapula. And then I'm now going to percuss in the same pattern, side to side, top to bottom. The next component in the percussion for the posterior chest is determining the level of the diaphragm and also diaphragmatic excursion. That means how much does the diaphragm depress down by when the patient deeply inhales. So, as we are percussing down, the normal sound, the normal sound should be resonant until we reach the diaphragm. Below the diaphragm, the sound will become tympanic because now that's the abdominal region. So we're going to do that right now. You don't need to start all the way from the top because we know the diaphragm doesn't stop up there. Okay, so somewhere around T6 is fine. So as I percuss down, listening for that resonant sound. So I know for the patient, we had a resonant sound here, but then when I got to this point here, it became dull. So we know that between the resonant and the tympanic sound is where the diaphragm lies. Now I'm going to ask the patient to take a deep breath in and hold, and as they hold, I'm going to continue to percuss down. And now we have more resonant sounds until this point where it becomes tympanic or dull again. Breathe out. So I know that between this point and this point is how much the diaphragm has depressed by. So now we have determined our diaphragm level and the amount of excursion it goes through when the patient deeply inhales. We need to perform this on both sides of the chest because the diaphragm are on both sides. So once again, resonant. Finding the level of the diaphragm as the sound changes over. And then from the same point again, asking the patient to take a deep breath in and hold. And it becomes tympanic right around here. You can breathe out. So once again, from here to here is our diaphragmatic excursion. We need to perform this bilaterally because we need to make a bilateral comparison of the diaphragm levels and the excursion. A normal patient, we should be expecting 3 to 5 centimeters of excursion, and that should be symmetrical bilaterally. and that completes percussion. Next, we move on to auscultation. So once again, using the diaphragm of my stethoscope, asking the patient to hug themselves, we're going to listen for a whole breath at each contact point. And next, I'm going to perform bronchophony. Okay, 99.
99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
And once again, you don't need to explain the normal and abnormal findings again because you have already done so for the anterior chest. Lastly, you have two special tests, the voice transmission tests. They are whispered pictoriality or egophony. I'm going to demonstrate both in this video. In the final exam, the examiner will pick one for you to perform, and that is only going to be performed on the posterior chest. So first of all, whispered pictoriality. So as I'm placing my stethoscope on the patient, we're going to ask him to say 99, but in a whisper. You probably can't hear this on the camera, but he is whispering. And make sure you are following the same pattern again. By the end of this lecture in lab, the patterns should be burned in your brain. Now for whispered pictoriality, in a normal patient, that whisper should now become very, very difficult to detect or even absent. In a patient where there is consolidation, that whisper will become quite loud and easy to hear. And that's what we call whispered pictoriality. It indicates consolidation, such in the case of pneumonia. And lastly, we're going to perform egophony. So we're going to ask the patient to continuously say E in a normal voice.
E.
Continuously.
E.
Now, in a normal patient, that E sound should stay as an E sound. However, if you can hear the sound sounding more like an A, then that means the patient has egophony, and that indicates presence of a consolidation, such in the case of pneumonia. And that's it for our respiratory exam.